we've made a great progress. We've talked about the new NK1s, our 5-HT3s, which are very mature, the use of corticosteroids, and different ways of treating. So where are the remaining needs in CINV, and what are the unmet needs? So Eric, what are your thoughts?
So I think we've done a good job of having guidelines classify chemotherapy broadly, but I think we need to incorporate those with patient risk factors and study this in a prospective way. So that's one very important one. The other is multi-day chemotherapy. And currently we take the worst offender and say that we're going to classify their antiemetics based on that. But is that really the best? Because if you're getting a low or even moderate emetogenic chemotherapy over multiple days, is that really high? Which then leads, of course, to the hematologic malignancy population, who really has been understudied, and it's kind of the wild, wild west in terms of what people are doing in terms of antiemetics in a very complicated and sick patient population.
What's your experience? You mentioned BEP, Dawn, and that's a regimen that's tried and true for testicular cancer, multiple day chemotherapy. Perhaps we don't use quite as much of it in general as we did before, but there still are very specific reasons, and clearly the hematologic malignancies, I'd agree with Eric. So what are your thoughts? How do you approach multi-day chemotherapy?
We try to be as aggressive as possible in those particular patients. And like you had said before, these are curable patients. We do not need them falling off the wagon or coming back to us saying they don't want therapy. You know, we need to get them through, and we need to be aggressive up front. And that's, in my personal opinion, I feel like we're still underutilizing the NK1 receptor antagonists. And I mean, we have all of this great data, we have all of these drugs, but we still are seeing 30% of patients have nausea. You know, a third, 1 in 3 of patients are still not being controlled. And so we still have a ways to go.
So do you give the NK1 on day 1 and repeat it, or do you, and how do you approach Palo for the same point of view with a long-acting 5-HT3?
Yeah, right now we're still only doing the NK1 on day 1. And with palonosetron, we give, if it's a multi-day regimen, we give it days 1, 3, 5, or every other day, depending on the duration of the regimen.
Okay, other thoughts?
Yeah. I think one thing to touch on is an unmet need, and we see this a lot in the lung cancer population, especially with the ALK inhibitors. There's a lot of nausea, and these are oral drugs that are dosed every day, sometimes twice a day. So in my population of patients in lung cancer, especially with the ALK inhibitors, I can struggle with how to manage nausea on an oral targeted agent that's taken every day indefinitely until disease progression, and sometimes, like I said, dosed twice a day. And how do we manage that? I mean, do they take a daily 5-HT3 orally? Do they take, you know, what would be the role of Dex or an NK1? Because that's for short term. We don't really have, I certainly don't want someone on dexamethasone every day. You know, and then we think about the other breakthrough medications such as prochlorperazine or lorazepam, but they have toxicities as well associated with them. So I think in my practice, that's something that we're a little bit struggling with, is some of the oral targeted therapies and how to manage the nausea.
Yeah, go ahead.
I'm sorry, we build into some of our oral regimens antiemetics. So we'll give them to start ODT tablets, for example, and tell us. And if they come back and they say, I'm continually nauseous, or they're coming back and calling us, we need more, we have to reassess. We don't know where we're going with it, though. Right. We really don't know how to change them over, you know, to continuous therapy or not. Obviously, it's not everybody, but those patients who are resistant, who continually break through even though we're not constantly treating them, we have to come up with a good way to treat them, and we just don't know what that is quite yet.
So I think this is an area that's very fertile ground for research. There's really very little research on this, and I totally agree with you. The ALK inhibitors can be very significant. You wonder about adherence with drugs. We do know that cancer patients do take their drugs more than others, but if you have chronic nausea, I suspect that there are patients who are saying, I'm going to take a couple of days break and
many
feel
of which
better.
are recommended to take on an empty stomach.
Right.
Yes.
Which makes it even more difficult.
Yeah.
So I'd like to see some trials within perhaps NK1s, these long-acting NK1s. Maybe that would make a difference, you know. And as far as I'm aware, there have been no trials reported with that, or even long-acting 5-HT3s. What about even in our best efforts, and we have breakthrough nausea, or even worse, refractory, where we've given therapies? What are your approaches now to breakthrough CINV?
Well, obviously, we look at what we're doing to begin with, and our experience with breakthrough has been not terrible. I mean, we've pretty much tried and handle it especially after the first cycle with the MEC patients who don't do well. When we put them on combination regimens, they usually do pretty well. So we're talking about a small percentage who are breaking through overall to a significant extent.
Right.
You know, if somebody once reports, gee, you know, I was nauseous ×1, we're not really looking forward to making any changes because it's not affecting life dramatically. That being said, we're looking at what we're going to supplement people with. We're giving them long-acting everything, pretty much.
Right.
So where's the supplement? If we're giving them long-acting 5-HT3, do we give them additional 5-HT3? I'm not sure what the benefit is. There is no additional NK1. The question is, as Eric brought up, you know, is olanzapine something that we should be looking at that point? And it might be the way to go, just for, you know, a different approach, a different mechanism, if you will, to see what's happening. We know there's multiple receptors involved, and we picked out the two most prominent to treat with our drugs, but that doesn't mean dopamine isn't the issue. It doesn't mean there are other neurotransmitters that are the issue in any particular patient. And it's kind of like the shotgun. At that point, let's see what we have, and maybe olanzapine is the way to start.
But in parallels, your goals of keeping costs down. You know,
Yeah.
we're talking about pennies here compared to some of these other drugs.
When you got to look at other reasons for nausea and vomiting, so, you know, those ovarian patients with a lot of ascites, or those head and neck cancer patients with a lot of secretions, you know, can you get by with potentially adding an antihistamine or a scopolamine patch that might substantially decrease the additional nausea or dyspepsia? You know, so thinking about those other little things that might be contributing to nausea on top of the chemotherapy regimen.
And I think remembering metoclopramide as well, you know, as a drug, if patients say to me, I'm vomiting after eating a meal, or I just feel full and then I'm nauseated, you know, something to increase GI motility, such as metoclopramide, can have, you know, some play in that area as well.
You may have delayed gastric emptying in a lot of these patients too, secondary to the treatments.
Sure.
And metoclopramide reverses. I mean, that's not a bad place to begin to think.
And also GERD is another, and patients can experience that as nausea. As we've talked about, nausea is multifactorial, it's subjective, and there are many different ways you can get to that sensation of nausea, whether it's anorexia or decreased gastric motility or an actual toxic effect of chemotherapy. So I think what I'm hearing is careful patient history, particularly for breakthrough or refractory, and then individualizing and personalizing dosing for that going forward, once you've established that you're giving the most effective regimen. So what do you think the future holds for CINV? Eric, you're a futurist. What do you see going forward?
So I think it will always be an issue, even with our targeted agents. And I think that's just because of these individual risk factors that we're still trying to tease out. I think that we need to prioritize it, educate, all the things we've discussed, and then, you know, deal with this in the real world. So currently, many of our decisions are being based on drug cost. And so putting that all together is really where we need to go.
Other thoughts about future needs and unmet needs?
Well, I think part of it right now, which we've mentioned a couple of times, is education. The unmet need is, in my eyes, drugs are available to treat many more patients that are being treated. And unless you understand their role in therapy and apply it, it's just not going to work. Obviously, you know, the drug is great. If a patient doesn't take it, it doesn't do a thing for them. So getting to the really the grassroots level, the treatment level, saying, you know, here's what we have, here's what needs to be done for best practice, and then how's the best way to do it in your practice? How's the best way to integrate this into your practice? Because obviously, based on surveys you mentioned, it's not being used. Effective therapy is just not being used in a vast majority of patients.
So to emphasize this point, education of practitioners, education of the multidisciplinary team, and education, importantly, of patients to report back to us, because this is a symptom that we can manage and hopefully prevent in the majority of patients. And even if we don't prevent it, we have other ways of working on this.
Absolutely.
That, and let's take education a step further. Educate payers. We shouldn't be running into situations where we have to beg to give the patient the correct regimen.
And we can perhaps educate them that the downstream costs, as we've mentioned, are something they need to focus on. It's not just about the cost of the regimen, it's what the consequences are, and that they'll probably save money in the long run if we give the best therapy up front. Well, this has been an extremely informative discussion, and before we end it, I'd like to get closing thoughts from each of our panelists, and I want to thank them for just an exceptional discussion this morning. So, Dr. Roeland, what are your closing thoughts?
Well, my closing thoughts are these, that we should always stop and think. That's true of many parts of our lives, but in this setting, improving our ability to control nausea and vomiting improves compliance and maximizes our ability to be aggressive.
Dr. Dolan?
I think we need to be more cognizant of guidelines and not become complacent. You know, there's still unmet needs out there. We still have patients with issues, and we just need to take our research a step further.
Thank you. Ms. Eaby-Sandy?
I would say know your patient. Do a thorough review of systems and history and understand what is causing their nausea besides the drugs that you're giving them, and then tailor your approach to managing it based on the patient.
Thank you. Dr. Levine?
I have to agree. It's about individualizing treatments per patient, per treatment, per their history. Put it all together and take the time to make that decision, most importantly up front. I mean, day one, that's when you have the most impact. Do it up front and you will save patient dissatisfaction with treatment. You will have better therapies in the long run, and everybody will benefit from it.
So in 2017, one of the buzzwords is personalized medicine, and what we're saying is personalized medicine as it relates to the prophylaxis of CINV is critical as well.
Absolutely.
So thank you all for your contributions to this discussion. On behalf of our excellent panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.